Now, we are a little bit ahead of the time, but I want to introduce your second speaker. We have Ottilia, and which is going to talk about the role of the nurse in patient with hypoparathyroidism. Ottilia is an advanced clinical practitioner and lead endocrine nurse at York Hospital in the UK. She worked over 12 years as an endocrine nurse specialist and as an intensive care nurse before. Ottilia is a member of the UK Society of Endocrinology nurse committee, as well as a clinical committee, and she's passionate about nursing aspect of the endocrine patient support. Ottilia has been a member of the working group who recently revised the ESE clinical guidelines for treatment of chronic hypoparathyroidism in adults, and she would like to share with you all her experience and learning on this condition. Please ask your questions throughout using the Q&A button, and they will be answered at the end of the session. And now let's welcome Ottilia, which will do the next presentation. Ottilia.
Thank you very much, Cosmina. Thank you very much for the opportunity to speak today about my experience as an endocrine nurse for the management of hypoparathyroidism patients, as I was very lucky to participate in the group kind of work when we revised the ESE guideline very recently, and I heard Lars in person talking about the subject, as Lars has given us a very good and in-depth explanation about the management and about the medical treatment of chronic hypoparathyroidism. I'm not going to detail this, obviously, and due to the limitations of the timing, I will focus on more the soft skills around the management of hypoparathyroid patients. I still touch very briefly about the condition management, but as I said, I will detail more about the endocrine nurse input and patient management in the chronic aspect. Hypoparathyroidism simplified by and described by the lack of PTH hormone and consequent hypocalcemia. I think this is the main symptom what we all as nurses account and recognize with patients, and the varying degree of involvement we have as endocrine nurses, dependent on the area or the actual country where we work. I recognize that the nurse involvement is very, very different in all countries. Here in the UK, we have varying degree of nursing input, and I myself only work as an outpatient support nurse, and therefore the acute phase of hypocalcemia is very often bypasses me. And most likely the diagnostic part is actually doctors or medics led. As Lars have explained, the majority of the patients do end up having hypoparathyroidism due to post-surgical complications. And the diagnosis as such, it's majority of the time, it's an acute emergency recognition, either still as an inpatient or following discharge. The diagnosis, as I said, if it is an acute presentation, it includes the lab workup and the ECG, but this rarely but can take place as an outpatient diagnosis as well. The acute management and the chronic management 6 months down the line are very well documented, as Lars have shown us as well. But as I said before, I will focus on the nursing role, which is really on the chronic late effect management mainly. The clinical presentation and the symptoms are very important from the nursing aspect for me, as we often are the first port of contact for the patient. The acute presentations, the tingling, muscle cramps, tetany, and by all means seizures, can be the presenting features. As I said, it's most likely will draw an emergency management in the A&E department. The chronic symptoms which are more likely to be the one what we are recognizing: the fatigue, increased anxiety, depression, cognitive changes, which very often described by patients as brain fog, the brittle nails, dry, coarse skin, dental abnormalities, and ocular disease. The diagnostic workup, it does include the biochemical profile, and that's very often described at the low calcium levels with low inappropriately normal PTH level. Serum phosphate very often high, and due to the lack of conversion of active vitamin D, the active vitamin D levels are low. Normal magnesium and normal creatinine levels, particularly in the initial part, are prevalent, and if the ability to do urinary calcium diagnosis is very often high due to the calcium excretion. In over hospital, as I said, the acute management is pathway-led, and it is dependent on the locality. I'm not going to go into details, but it is including the IV calcium replacement and the cardiac monitoring. Very often this does require a lengthier stay in hospital, particularly at the diagnostic part, but often even in a hypocalcemic state, during the chronic management, this requires an at least overnight stay in hospital, which very often patients find very distressing. The chronic management, Lars gave us a very detailed explanation, and the revised guideline will give very clear guidance about the target ranges and the target levels. As Lars described, the flow chart, which I find the most the easiest to use, is still on the process, and you may find that in the published guideline this will look completely different. But in all manners, the conventional treatment therapy, which very often the first line treatment, will include active vitamin D replacement and potentially calcium supplementation. I think it's important to emphasize that we should aim to establish the active vitamin D dosing on the level that the dietary calcium intake is providing that appropriate calcium level, and the patient is able to avoid taking calcium supplementation. I recognize this is again very specifically kind of local departmental, potentially consultant decisions, but me as a nurse, I'm always aiming to completely establish the patient on vitamin D replacement therapy, active vitamin D replacement therapy, and focus on dietary calcium intake to reduce the possibility of calcium excretion through the kidneys, and essentially increase the possibility of later complications via kidney stones. The monitoring does include the symptoms in all cases and biochemical profile. Each and every adjustment of dosing would draw the requirement for rechecking the blood tests and the blood ratios at week or maximum 2 weeks after. The follow-up blood test is very important. That's how we are assessing the actual effectiveness of the treatment, and equally to establish if the patient is experiencing any of the symptoms continually, or indeed it's alleviated. I know that we are hoping for PTH replacement therapy to be well established in over practice. Currently in the UK, it is difficult, and it's very minimal, as anticipation is that this will increase in the future. Again, the guideline will give very good practical advice in relation to switching treatment. While we are looking at the practicalities or the target ranges, as clinicians, we can get quite focused on the primary targets and also secondary targets to be achieved. I think for patients, very often this is a very stressful experience where they recognize that despite their efforts, the targets are not achieved, or indeed the adjustment is not drawing that improvement what they are hoping for. I do find that this is definitely a journey following the operation, particularly if the hypoparathyroidism was an outcome of an other surgery. It can be a very daunting journey, particularly in the first diagnostic part for the patient, and this has to be incorporated in the nursing management. And this is when I will really get detailed about the nursing role. I do see that while the assessment and monitoring of the treatment requirement and the treatment effectiveness is very, very important. And as I said, we are able to focus on this from the beginning. The engagement with the patient gives us the opportunity to really recognize and monitor long-term complications, or indeed the development of long-term complications, and most importantly, to engage with the patient and educate over patients regarding their symptoms and their long-term management. The empowerment, what comes from the patient education, really has an impact on the psychosocial aspect of the care, and this is recognized to be a major factor in chronic management, and in particular with calcium management. Again, I return here just to clarify the nursing role. It is in over hospital, the monitoring is majority of the time is actually nurse-led. We do initiate the blood test, which include obviously the adjusted calcium levels. This depends on the centers. It's either adjusted to albumin or iodide, the phosphate levels, magnesium, and the kidney function. We aim in stable condition to monitor this 3 to 6 monthly. As I said previously, any treatment change draws the requirement to recheck the calcium levels approximately a week or 2 weeks after the change being made. As Lars said before, PTH levels should be measured yearly just in case any recovery of the PTH production would be evident, and this could actually be recognized by the varying calcium levels as well. 24-hour urinary calcium measurements should be annually or biannually. This is to ensure that minimal calcium excretion is happening through the kidneys, and with that reduce the possibility of long-term complications via kidney stones. The hypo and hypercalcemic symptoms should be assessed each and every contact with the patient, and these can be varying degree disclosed by patients. If your system is anything like always, the majority of the follow-up is telephone appointments, and the information obtained over the telephone, I do find that a clear understanding and guided open questions can be very useful, where we target essentially the symptoms to be disclosed without giving the words into the patient's mouth. Variations in the actual treatment therapy should draw the discussion about adherence with the medication. I do find that some of the treatment options really include a lot of tablets, and pill burden is a real problem with long-term chronic management. Discussion about varying degree of adherence does help engagement with the patient, and more likely to lead to an understanding of the necessity of a well-replaced calcium level, and equally to encourage the patient and make them understand why is that for their health benefit. The discussion should include long-term health monitoring that refers to kidney problems or any muscle or psychosomatic changes. Long-term complications do include mainly around kidney and nephrocalcinosis, these can be direct effect of calcium over replacement, and when we are not achieving the calcium levels on the lower end. Musculoskeletal and neuropathic pain can be a symptom of long-term complication, and mainly fatigue and weakness. Anxiety and depression is very often reported by patients, unfortunately, which is varying degree of focus. And needless to say, the ischemic heart disease and cataracts, which is more likely to be a long-term complication with non-surgical hypoparathyroid patients, they should be recognized and monitored regularly. I suspect these will be a part of the annual review, which very often in center is doctor-led, but discussions about blood pressure management and in general health should be each and every review focus as well. Quality of life discussions are always part of over management. I suspect in some cases it is worth quantifying, in particular if depression scales or quality of life questionnaires in practices can guide patients and can enable the documentation of decline over time as well. I would like to speak about patient education and the importance, as I said before, simply educating over patients about the symptoms and when to ask for help can make them feel more secure and empower them to be more in control of their own condition. From patient descriptions, I do find that they find it most distressing that they feel out of control or indeed not in control of their own body. When they require hospital admissions, that further emphasize that vulnerability and anxiety. This can lead to more complex health anxieties and avoidance of E&E attendance, which of course can draw further problems where they access help too late, or indeed they have long-term complications development earlier due to these disengagement. Simplicity of encouraging hydration to prevent kidney stones. It's again very simple, but unfortunately we do find that normal drinking habits means very different for each patient, and it's well worth to emphasize the 2 liter a day clear fluid intake, as very often we find the patients nowhere near drinking the advised amount. The carry medical alert identification, this is I'm sure dependent on where you live, the availability to this, but good examples can be recognized in the patient help support pages, and equivalent can be really copied in your local environment. And here I go on to this side. I do believe that some of the patient information leaflets, I always find that unfortunately patients are very engaging within the conversation and consultation, but they go home and they forget half of the information that we provide. For that reason, I always make sure that they are provided either with access to a QR code, which is leading them to an electronic version of the information leaflet, or indeed to print out a hard copy of the information leaflet and give it to the patient to take it home. It will make a difference. It will bring back all those words which was given at the consultation, and they are able to refer to this later, 2-3 months down the line. I find these the Hypoparathyroid UK website very useful. Of course, it's English only. However, I have noted that the European Society of Endocrinology website does have patient information leaflet for hypoparathyroidism on different languages. The information leaflets themselves are very, very brief, but very informative, And probably it's a well-invested energy to translate them in your own language if you are living in an area where it's not available currently. I put in this patient quote, which I found very much a descriptive what I hear often. I feel confident with my doctors. However, I think you are left to cope on your own too much. And in between appointments, you have to manage things yourself, which is difficult. There is no home testing for calcium levels. This leads me to the part regarding the psychosocial aspect of nursing care. I find that hypocalcemia patients, hypoparathyroid patients, do have a lot of health anxieties, unfortunately. Due to the fluctuation in the calcium levels, even when they are well replaced and the treatment is appropriate for them, they account rapid changes in their calcium levels, which lead to immediate symptom cluster. I do find this can lead to over testing and increase the tendencies to E&E or any kind of acute settings, which leads, it's unfortunately reinforces that health anxiety, and it can be quite a difficult cycle. Needless to say that I'm fighting for these patients in particular who are not coping very well, and that's where the PTH therapy most could be a very good addition for their health, as the quality of life is evidently not there. It is a difficult conversation with patients why they are feeling anxious about their levels. Sometimes I hope that just reassurance can really help them. But in general terms, we recognize that due to the dependency of the pill burden can lead to significant changes in their life, which can lead to changes in their work arrangement. It can put a lot of pressure on their household, and that leads to a long-term quality of life decrease. The fatigue, the accounted fatigue, and the increased hospital attendances are further burden on long term. And this is, of course, with any chronic condition, can significantly affect patient mental health. For that reason, again, I find that these discussions, particularly for patients who are frequently attending, should take place targetedly. We should ask, how are you coping? How are you doing? And not to shy away to hear that they are struggling. And also, if you have means, to refer to appropriate support. This may be an online talking therapy. I do find that NHS talking therapy is a very useful tool in patient management and anxiety management, and often patients report back that they find it useful. Peer groups can be very useful, and this is where it is helpful to know your available peer groups. Again, the ESE website or Hypopara UK website. Actually, I found international peer group, peer support details, and do your research, find what's available locally, and direct your patients towards that. It is well worth to make a little patient information about your peer support group, and you can just hand it out in your conversation. Patient resources, I have detailed here a couple. Unfortunately, again, they are English-based, but equally it may lead to your understanding where you can guide your patient. All these websites provide very good, simple explanations about the condition and can guide patients to the right sources. I always dread when patients just Google their condition. You don't know where they are taking their information. These websites are very detailed, and they are giving very practical insight to patients how to manage their own condition. And finally, I would like to talk a little bit about us nurses. I think sometimes it's difficult to keep up or to know exactly how to educate over self or how to provide that vital information to patients to feel confident about over support. And for that reason, I really would like to draw your attention to the Society of Endocrinology Competency Framework for Adult Endocrine Nursing. The third new edition is very detailed. It guides any one of us through the process of becoming an expert of the particular field. In this case, how to manage a patient with hypoparathyroidism. It is really very practical and it can guide your learning process. It will guide how to research your knowledge and how to embrace, how to put it in practice to provide the patient with the appropriate support. To summarize, as I said, it's important that we nurses do recognize the acute and chronic symptoms of hypocalcemia that can lead to the appropriate management. As I said before, even within a chronic state, acute hypocalcemic symptoms can occur and the patient may require acute management. If you are looking after a patient and support them through their chronic management journey, the European guideline provides very practical and detailed information about primary targets and secondary targets, what we should be aiming to achieve in over patient care. But most importantly, on the end as nurses, how to educate over patients regarding their medication adherence, the diet, what contains calcium. I do find these trivial symptoms, simple steps can change people's life when they understand what they're supposed to do to manage their condition well. And also on the end, that please do consider your patient's psychological need and their mental health due to managing a condition which is providing ups and downs and life-changing milestones in their lives and provide that help what they need. Thank you very much.
Thank you, Ottilia, for such a amazing presentation, actually, of the role of the nurse in managing hypoparathyroidism. When I agree with you, it's quite a complex condition to manage. Now, I will just check if there are any questions. So if you do have any question for Lars or for Ottilia, please use the Q&A button. If not, I have a question actually. With the new medication, the Yorvipath, is there appropriate time in the day when it needs to be used, or I don't know, is it the morning time that it needs to be used, or is it later on? Is there a time element?
Yes, as far as I remember, doing the studies, patients were recommended to take them at evening time, mostly because they may cause some deviations in blood pressure and pulse, and therefore they were recommended to take it before bedtime. But it turns out that it is not of major importance. So actually, I do not believe it is of major importance whether they take it in the morning or in the evening. But the most important thing is to take it once a day. But it has a long duration of action. So if they forget to take an injection, they will not experience severe hypocalcemia because they have forgotten a single injection. If they remember it within 12 hours after they should have taken the injection, they can take it. If more than 12 hours have passed since they should have taken the injection, they just skip it and take it the next day. So it has a long duration. So that's an advantage of this treatment, I believe.
Brilliant. And one question actually for Ottilia as well. Once the patient is being started on treatment, how long does the patient experience the symptoms of hypocalcemia? For how long they feel it? I don't know if my question makes sense.
It makes perfect sense. I think it's really varying. That's the problem. And I think some patients continue to experience the symptoms despite appropriate replacement. And I think that's where the quality of life and kind of the further treatment escalation comes in. So while we would expect the symptoms to resolve when the biochemical normalization is achieved, it's often bypassing that. And of course, the fluctuations in the calcium level, what patients don't tolerate very well, and they recognize, and they find it very distressing.
Yeah. I have another question actually in regards if you notice any difference in patient response between alpha-calcidol and calcitriol in the management of the hypoparathyroidism.
I mostly use alpha-calcidol, but that's mostly due to traditions that in Denmark we use alpha-calcidol. I know that other countries use calcitriol. The dose of calcitriol is half of the dose of alpha-calcidol. I do not have comparison between the two treatments, but I believe that in general they works in a similar manner. So it's mostly a matter if patients have adverse effects to, for example, alpha-calcidol, I shift them to calcitriol and see if they tolerate it. But in gross terms, I think they have similar effects and similar side effects. So there's not a big difference between these two vitamin D analogs, I believe.
And I think another question actually for both of you, how do you manage people which don't comply with the treatment option? Because I believe all of us will have them kind of patients.
Yeah, compliance is a difficult question. There's some difference because if patients have symptoms of hypocalcemia, low calcium levels in their blood, they often feel it immediately because it causes symptoms immediately if calcium levels suddenly drops. But on the other hand, if calcium levels slowly rise, patients may not have symptoms from this. And having too high calcium levels in the blood causes an increased risk of renal calcifications, nephrolithiasis, and renal stones. So it's more problematic with the patients who take too much medicine, ending up with too high calcium levels in their blood, because they do not necessarily feel that they have hypercalcemia. But if they have hypocalcemia, too low calcium levels in their blood, I'm pretty sure they feel it rather fast and will start taking their drugs because it's unpleasant to have low calcium levels in the blood. What do you think, Ottilia? What is your experience?
I think my concern is always around varying levels. That's when you really start zooming in. That is it because of compliance or adherence to the treatment, or is it absorption? And that's what makes it difficult. And I think in those cases, it's just honesty. I really try to engage with the patient and try to gauge that is it a problem that you're not taking your medication, because it will have a major implication on the actual treatment course what we are changing. it's always, as Lars said, once we increase the dose and it's not required because it was purely an adherence, it may take a long time before we realize that the medication has been overprescribed and it can cause end organ damage. So this is where the actual assessment need is really that is it adherence, the varying degree, varying levels, or is it treatment efficiency?
Thank you. And there is a question for you, Ottilia. Which quality of life questionnaire are you using?
So I'll be honest with you, I don't use any, and for the purpose because we have very limited resources to do anything about it. And I think I use just literally talking. So we documented how we recognize the patient's mental health to be at the time. But equally now that Palopeg is around the horizon, I am thinking about starting to quantify much more closely the health-related questions, quality of life questions. And there are, as in guidelines, 365, something along those lines. So there are recognized quality of life questionnaires, which helps the continuity and the actual recognition in decline. Currently, as I said, we didn't use purely because we had no means to do anything about it in the sense of addressing it more than just referring patients to really kind of remote access therapies.
Thank you. And there is another question for patient recovering following surgery and started to have detectable PTH. How do you wean off alpha calcidol?
We try to lower the dose of alpha calcidol slightly, and then if it works okay and the patient is okay with lower doses, we remeasure calcium levels and PTH levels in the blood, and then see if it's possible to lower dose of alpha calcidol any further. It is sometimes a bit difficult with PTH levels because sometimes the blood test shows that PTH is actually present in the blood, but despite having PTH level low, maybe low in the reference range patients, they do feel symptoms of hypocalcemia. So alpha calcidol is needed despite PTH being measurable in the blood. In that case, they have a kind of PTH insufficiency. They produce PTH, but not enough PTH to maintain a normal calcemia. So if we think that the patient is recovering, we should try to reduce doses. And I believe it's very important to do so. And that's actually the reason also why we recommend to aim at plasma calcium levels low in the reference range or slightly below, because that allows for producing PTH. If calcium levels are high in the reference range, it may suppress PTH secretion. So it's important to trying to have calcium levels in the lower part, in the lower half of the reference range, or slightly below.
Yeah. And there is another question. Are there, meanwhile, any experience what happens if a patient has to switch back from your path to calcitriol and calcium? There were a lot of serious problems when NATPAR was taken from the market. So I don't know if that's one question for you, Lars.
Yes, I know about these troubles when Natpara was stopped, that patients may have developed hungry bone syndromes needing much higher doses of alpha calcidol and calcium following stopping treatment with Natpara. There's so far only very few patients who have been treated with Palopec. It's a brand new treatment, as you know. So we have only very little experience with patients stopping the treatment. And these experiences are a bit different some report that they do need extra doses, or we should try to trap off the treatment slowly if possible. Other have experienced that it is actually not a big problem because Palopec has such a long plasma half-life. So if you start treatment with active vitamin D at the same time as Palopec is stopped, there'll be an effect of active vitamin D at the time when Palopec weans off. And the only thing I can say for sure is that we have to get some more clinical experience with this treatment in order to come with some good recommendations on how this can be done.
Yeah. And is there any role of genetic testing in hypocalcemia and hypoparathyroidism?
Yes, definitely there are. If the patients have not had surgery to the anterior part of the neck, total thyroidectomy or extensive parathyroidectomy, then I believe it's a patients with non-surgical hypoparathyroidism. And I always do genetic testing in these patients if there's no obvious reason for why they have developed hypoparathyroidism, because often, sometimes at least, you can find a reason, which I believe is very important to find a reason for why they have developed hypoparathyroidism. So I use genetic tests a lot if there's no obvious explanation for the hypoparathyroidism.
Thank you. And I think, Ottilia, I think this question is for you as well. Do you feel like you send some people to get testing if for hypoparathyroidism in your experience, obviously in the hospital?
So we have very similar approach as Lars just described. So if it is something which there is no surgical intervention prior to it, and we do test for genetics, yes, with variable degree of outcome. Nevertheless, it's offered to patients.
I'll just check if there are any further questions. And I think there are not any other further question unless anybody else wants to give us any more insight. And I think another question that actually Kirsten just asked, is the management of pseudo hypoparathyroidism the same as the hypoparathyroidism, or are there any distinct any different approaches?
It's a very good question, because patients with pseudo hypoparathyroidism, they often have very high PTH levels, and they have a resistance to PTH. So it is treated with high doses of active vitamin D and calcium, similar to conventional treatment of post-surgical hypoparathyroidism, for example. You may consider whether it's actually possible to treat pseudohypoparathyroidism with PTH injections, for example, Palopec. But as far as I'm aware, there is no clinical experience with using that treatment approach. But it could be interesting to give it a chance and find out whether it makes sense. A priori, I'm not sure, but it could be very, very, very interesting to find out whether it's possible.
And I think one of my other question as well is, did it ever happen that the patient was overtreated with, obviously with calcium supplements, that he experienced, cardiac arrest or any adverse outcomes because obviously the supplementation was too much?
Luckily, I'm not aware of patients who have had cardiac arrest in response to treatment with hypoparathyroidism. But of course, there is a risk if they are overtreated. I think it's In terms of too high doses of calcium, it is mostly the kidney which are of concern. I don't think it affects the heart to any major degrees, but overtreatment with active vitamin D can definitely cause severe hypercalcemia and affecting the heart and not only the kidney. So, but low calcium level causes also adverse effects to the to cardiac conductivity. So yeah, it's difficult, but the heart is definitely affected by calcium level. Calcium levels in the blood are normally very tightly controlled because it has so many effects on the different physiological physiological functions. So calcium should be tightly regulated.
And we have another the question about the PTH assay and if there is any assay interference.
Assay interference may occur, and some patients may develop antibodies affecting the PTH assay, and therefore, in such cases, PTH levels may be measured too low if patients have developed antibodies against the PTH assay. And if something doesn't fit, if something looks too strange, I can only recommend trying to measure PTH level using another assay, because often these different assays, they do not have cross-reactivity to, for example, antibodies interacting with the specific assay. So if something doesn't fit, try using another assay for assessing PTH levels in the blood. That's my best recommendation.
Thank you. I think that brings us to the end of today's insightful webinar on the hypoparathyroidism. I think we explored the physiology and the diagnosis and the treatment of this rare, but I would say very impactful endocrine disorder. A special thank you to you, Lars and Ottilia, for your amazing presentation. And I would also like to thank everybody for their participation and questions. Just before we go, the webinar recording will be available on the ESE website in the next few weeks. And please do take a moment to fill our feedback form to help us improve and tailor for future sessions. Stay tuned for upcoming webinars and related endocrine topics. And please make sure your voice is heard by scanning the QR code on the slide and take part on this important survey, which closes on the 16th of November 2025. It is crucial that the nurses' voices are represented. On behalf of the ESE organizing committee, I thank you once again for joining us today. And I would always say, stay curious, stay connected, and keep learning.